just done a great job in organizing this session and bringing all these great speakers to the table. So I will, and then for the speakers, the basic format is, I think you have 15-ish minutes with 15, 20 minutes with some time for Q&A up to 10 minutes after, so about a half an hour for each one of these things. And you can share your screen if you have slides. And then so for each one, I'll do a little read some of these bios and then hand over the mic for the session, and then we'll kind of bring it back and start the next one if that works for everyone. So the first one is leveraging strategies, collaborative workforce development initiatives with Rod Granger and Miranda Ramos. Rod Granger has been the CEO of Mendocino Community Health Center since 2022. He has 30 years of healthcare management experience with a strong background in healthcare finance. And prior to joining MCHC, Rod was the executive director of the Long Valley Health Center for the prior 10 years. Miranda Ramos is the program director for the Alliance for Rural Community Health, known locally by its acronym ARCH. Her work finds her collaborating with partners across the region and across sectors to improve access to and quality of comprehensive health care for the communities of Mendocino and Lake counties. She likes to ponder big, root cause questions and approaches her work through the lens of emergent strategy. So with that as an introduction, Rod and Miranda, the floor is yours.
All right. I'm not on mute, so
You're not on mute. We can hear you.
very good. Well, thank you for having us here today. And Miranda, were you going to share screen, or looks like we're on that? There we go. So we're going to tell you just a bit about a few things we have going on in Lake and Mendocino County, and a few things still under development. And I think where I would start is fortunately or unfortunately, I think a lot of what we've been able to accomplish has been dependent on various leaders that have been at different organizations. And those people are the people who either make things happen or put up barriers that cause things not to happen. And so we were fortunate, probably 5 or 6 years ago. I was running Long Valley Health Center in Laytonville, and we had a situation where we were getting out of sync with our pharmacy services, and they were the owner of the pharmacy was thinking about shutting down and moving his family and business, or moving himself mostly down to Southern California, where he had another business and his family spent most of their time. And so we were looking at a situation where we were going to lose pharmaceutical services for our community. I went down the hill to Willits, and I met with the chief financial officer of the Howard Memorial Hospital, run by Adventist Health at the time. And the CFO, I learned his name was Judson Howe. Probably many of you have come across him, because he stayed in the community for some time. And but he and I started working together on that project, and they had just opened up a commercial pharmacy, and so we were able to talk through how we might be able to partner with them and keep pharmaceutical services in the community. And through that project, he and I both realized in each other this characteristic that we were into collaborating, and we knew that we couldn't. This wasn't about competition. It wasn't about us trying to invade their market or them trying to come up and take over our pharmacy services. It was about, hey, you guys have a strength here that we need, and let's figure out how we can work together on that. And so he and I developed that relationship over the next few years. Then a couple of years ago, he had met up with another collaborator, actually from Kansas this time, and came back and started this incubate program. And incubate, I have to say the name came from Kansas. It's a very rural and agricultural community, and so they do a lot of incubating from a lot of their different crops and animals and all of those things. And so it fit nicely into their vernacular. But we were looking at it in our community to really figure out how we can retain residents that were coming through our family practice residency program. And that was the primary objective at the beginning of Incubate. But as we got into it and started realizing why people weren't staying, so they've had the residency program for, I think, 3 years at that time, and they were unable to get any commitments from the residents to stay in the community. And but as we started looking at why people were leaving, we realized that it wasn't just residents that were leaving. We had this problem with our full-time staff that we had hired at the hospital and at the clinic that I'm now running, Mendocino Community Health Centers. And so we decided we really needed to broaden our scope and really look at what are the factors that are causing providers either to not come here, we're unable to recruit them, or when they do get here, they don't stay. And so it's been a couple-year journey. Unfortunately, Judson Howe has moved on to bigger and better things, but we're still running the program very collaboratively. And in the beginning, it was just my clinic and the Adventist Health hospitals, because we were looking at it mostly in the Ukiah market. And since then, we've broadened it out and invited the other FQHCs, federally qualified health centers, throughout Mendocino County to participate in that, because we're all struggling on this and figuring out how we can be better together and stronger together. And we've had some significant successes. We have retained now some residents through the program. We've made changes in, thank you, Miranda. We've had changes, some of the changes that we made that are helping providers feel more engaged. At the hospital, Judson created a hospital physician leadership group. And they had their standard, medical executive committees and the other committees that are very typical in hospitals, but this hospital physician leadership group was specifically designed for physicians to have a voice directly to administration. It wasn't a governing group. They didn't have authority to come in and change the way the hospital was being run, but they were able to sit down on a regular basis with the administrative team and say, these are the things that are working for us and these are the things that are not working for us. And so it gave them a voice, and it's now become one of the strongest groups in the hospital. I mean, they have instigated more change and implemented more change through that group than many of the other standing groups that they've that were already existing. And you see some of the other things that we're working on there that are helping create better, stronger relationships. One of the challenges of coming into a rural environment, you don't know who to refer to. You kind of come in and in some of the smaller clinics like Anderson Valley and Long Valley Health Center, you don't have a ton of colleagues to ask. Some days you're out there on your own. So what we've started now is this primary care provider specialist learning sessions where we're having our specialists hold in services for the primary care providers and just giving them a little more education about their specialty, whether it's ear, nose, and throat, or gynecology, or gastroenterology. And it's not just sharing information with them, but it's actually building relationships. And so they're having to take some time out of their day and their busy schedule. It's cutting into their revenue, but it's also increasing their referrals and making the referrals more appropriate. And so you're not having primary care provided at the specialist office, and you're getting more complete and comprehensive care in the primary care office. So those are just a couple of the things that we've been able to facilitate, and we're actually seeing a stronger retention rate. And so we've seen our turnover rates go down, and we've seen our recruitment rates go up. I was just on another meeting here about an hour ago where I was reporting out some successes at our clinic. And over the past 12 months, we've actually increased our number of providers by 8 in a net. And we have about 80 providers in total. So we increased our provider count by almost 10% over the past 12 months by some of these efforts. Miranda, were you going to take this slide, or have I been jumping all over the place, which is something I typically do?
I'm going to go back a couple of slides, I think.
Okay, great.
Oops, I'm going to go the wrong way is what I'm going to do. Here we go. So one of the, well, I should go even further back than this. I think from what I understood from our conversation with Tina, not necessarily everybody in this room works all day, every day in healthcare like Rod and I do. So here's probably something that is not surprising to any of you, even though you don't work in healthcare all day, every day, which is we have significant shortages of health professionals. You may have noticed that a lot of the folks you see as your providers are a little bit older. Certainly in Mendocino County, we have some limits in the access for post-secondary education around workforce for the health professions. As we've got these these are happening everywhere across the whole country, but they're happening here. They have been for COVID-19. And so the work that Rod and Judson and the initial work around the Incubate initiative was really, to their great credit, getting really collaborative to work on this thing that everybody working in healthcare is working on their own every day, right, Rod? Like this is what health center executives think about all day, every day, is how do we have more and better and more effective delivery of healthcare. And so they got real collaborative. And then they got even more collaborative when they spread it out to the rest of the county. And we essentially determined, okay, well, what are the drivers of the things that are going to improve the retention and recruitment to solve those problems that we saw in the first slide there, or the slide I just showed you. And Rod's talked a few. The items here in blue are all things that we're working on together through the Incubate initiative. As Rod mentioned, you've got Adventist Health, the hospitals, all of the federally qualified health centers in Mendocino County, rural health clinics also involved, and the Indian health centers and public health as well. So trying to be really expansive in that work. And then I do want to highlight one of the items here, the Healthcare Education and Workforce Summit. Maybe some of you folks on this call are going to be at that next Thursday at Coyote Valley. We're going to be there. Rod and I will be there, as will many members of the Incubate Initiative and many other people who are working in healthcare across Mendocino and Lake County, but so will a whole bunch of leaders from K-16. And the purpose of that summit is for healthcare to talk to K through 16 education and K-16 to talk to us and to figure out some creative ideas about what we can do locally to improve our long-term pipeline for healthcare. Just to highlight that and say you could still register for that if you haven't. There's still a few spaces left. We already have, I think, close to 120 people planning to join us, and it'd be great. Come on down to Redwood Valley and join us for that. Let's see. Rod, I am going to call on you a little bit to talk about the mini Z, but I do want to say that we had these three kind of at the outset of the refresh of Incubate. We talked about, all right, well, what are our measurements for success on this? And you can see Rod's already talked a little bit about the successes at his specific health center around the increase in recruitment of medical providers. Another piece of this that we did, because of course, if you retain high quality medical providers, you don't have to recruit as many, right? So making sure that they're feeling well cared for, engaged with their job, enjoying where they're working and wanting to stay in the community for a long time. So having some surveys and interaction with them to find out how things are going for them so we can make sure we're doing the right stuff to keep them. And so one of our metrics for success is increasing the percentage of providers responding that they strongly agree with the question that they're satisfied with their current job. And we did a baseline survey. We did the mini Z. The questions are down there in the bottom part of the slide. And this is a nationally, I don't know, maybe it's an internationally used survey, but it's used by the American Medical Association to assess provider engagement and satisfaction in their jobs. And it's those 10 questions that you see there. It's pretty quick. So we did a baseline survey last October, and we had 43 respondents. And at this time, that was before we had our real strong expansion across all of the healthcare providers in Mendocino County. So it was kind of pre-buy-in. So we were pleased to have 43 individual provider respondents. And 28% at that time indicated a strongly agree with that statement. So we definitely have room to grow. I do want to mention that 40% did indicate they agreed with the statement. So it wasn't terrifyingly in the other direction. And then our other metrics, of course, are an increase in the number of FTEs. I know we have a limited time, so I won't go into the detail of why FTEs is more important than number of providers, but I promise you it's real important. And then also the increase in the number or the percent of the family medicine residents who choose to stay with us. We did have another aspect that, while not directly connected to Incubate, we wanted to talk about as a really effective strategy for us in our region. And Rod's going to talk to us about this. Some of the shared services that are already in place and are really, I think, from the day-to-day work I do, I know mostly about the impact in the increased serving of the patients, et cetera. Rod's going to be able to tell us a little bit more about what the key details of the finances of that and why these are excellent financial strategies.
I think one of the principal changes that we looked at that I've observed as we start to think about how we work more collaboratively together is what our mission is And if you go through and look at what the mission of any healthcare organization is, it's about serving our community. And therefore, if you really believe that, in getting our patients healthy and having a healthy community, and if we really believe that, if we're working hard to recruit a provider and they happen to end up at the Coast Clinic instead of my clinic, it's a win. Our community won, and they're going to be healthier because we were able to do that. And so we've got some unique, I think it's it's a mindset shift that you have to make, and to say, this isn't all about my organization and making it better. This is about playing an infinite game, not a finite game. There's not winners and losers. This goes on. We want this to be going on long after I've retired and all of those things. And there's a whole new crew here running it. We still want our organizations to be here taking care of and helping our community be healthy. And so, and that happens through this network of organizations. And the more we can keep working together, the other, one of the other challenges, especially when we get into specialty services, being in a small community, we don't have the volume at any single clinic to be able to support someone that's coming in as a specialist. And one of those specialty areas that's really true of is psychiatry. And so we had a great opportunity, and our recruiter up in Laytonville started this effort. I think it started just after I left the clinic, and up there, and had come down here to Ukiah. But we hired a nurse practitioner who now serves 4 of the 5 clinics in the county. And so she takes time. She's actually does do some traveling and spends and sees patients in person at these clinics. And then, of course, she does a lot of telemed to make her life a little bearable, because when you're talking about traveling between Laytonville and Wallala and Fort Bragg, that's a whole lot of driving going on over not the nicest straight roads and highways. So, but that was one of the efforts that I think we've been really successful on. Another was fiscal services, which is completely outside of the medical realm. And we had a need at several of our clinics. They had been using an outside accounting agency to do some of their accounting and some of their year-end work. And that organization was going through some serious changes and really jacked up the prices on the clinics and cut the services at the same time. And so we had at one of our Arch meetings that Miranda coordinates for us, we started talking about that. And I said, well, we're looking at hiring a new chief financial officer. And what if we brought that person in to be the chief financial officer of all of the clinics here in Arch? And we could actually, then we might have to hire a couple more accountants in my department, but we'll create a financial services department that will then, and you'll help us pay for that. And so we were able to avoid the cost increases that their outside company was proposing, and have actually been able to run it at a lower cost out of our department here at MCHC. And all of the clinics now are utilizing that services. That's not 100% true. One of the clinics is independent, and their accounting needs are far simpler than the rest of us. And another one had a really a great relationship with a different organization than the others were relying on. So it's 4 out of the 6 Arch members are using that financial services. And of course, we're We've had invitations all the way from Shingle Springs over near Reading, and inviting us to come over and talk to them about adding their clinics. And so it's become a model that's looked at across Northern California now. And then obstetric services, we have a couple of things going on. One is we've had a shift in where the OBGYNs work. In order to run an obstetric program, in the United States, you have to have an OBGYN overseeing the services. And you can have family practice physicians delivering babies. You can have certified nurse midwives, but they all have to be supervised at some level with an OBGYN. And over the past few years, the OBGYNs in the community moved from the hospital to my clinic here in Ukiah. And so now we have 100% of the OBGYNs working for a clinic, and the hospital has no OBGYNs, but they have the labor and delivery unit. And so we saw this shift happening. And so I sat down with Judson and his successor, Jeff Mock, and we have been able to work a collaborative relationship there where they are paying us for services that the OBGYNs provide at the hospital and provide all that oversight that's necessary for that. And what it's done is it's actually reduced the costs at the hospital and shifted the costs to the clinic, but not to the degree that it's overwhelming us. I don't know if you're familiar with obstetric services at hospitals. OBGYN or obstetric services, labor and delivery is typically seen as a loss leader in healthcare. Almost every hospital around loses money on their OBG or their OB products. But for every baby that's born, there's a brother to that baby that twists his ankle and ends up in the emergency room. There's a dad with, and they get the family hooked at the hospital, and that's where they come for their services. And so they look at it as a loss leader. So, and that was true with the hospital here in Ukiah. But now it's a little bit less of a loss leader, and together in the community, we've been able to balance where we're absorbing that cost to provide the services. And I think that's another kind of a big mind shift that we had to make. And that's another service that we have a hospital next door to our clinic in Lakeport. It's a Sutter Health Hospital, and they are really struggling with their obstetrics program. And so we're in negotiations with them now to see if they can help us recruit more OBGYNs and actually provide a similar relationship with them. We also, some of our OBGYNs are visiting some of the other clinics now and providing consultative services. And so it's really we've really raised the level and the quality level of obstetric services throughout the county by working in this more collaborative fashion. So was there anything else, Miranda, that I skipped over that?
No, I think we pretty well covered the items we wanted to share.
Yeah.
Awesome. Well, that was perfect timing and super informative for somebody who's not in the medical space myself. The power of collaboration, shared resources, and this is like you're getting more for your dollar across the board. So I think it's great examples. And so a lot of times what happens here is people give great presentations, and then there's a lot of thinking going on. And sometimes you get questions in the chat. Sometimes you get questions by using the hand raising, and sometimes people will follow up after. So I think We have a couple of minutes. If there are any questions that folks have a burning question for the first, for Rod and Miranda here. Here's an opening. Maria's got something for both. Oops. But maybe you'll follow up along the way, Maria, or do you want to give you a moment to find the unmute button? Okay. Well, um, thank you, Rod and Miranda, for a great
Thank you.
presentation. And and we will post all this and people can follow up. And it looks like Maria will be first in line with that.
All right. Thank you. It's our pleasure.
Thank you. Okay. Moving right along, our next speaker in this group probably needs little introduction, but I'm going to take the opportunity to read some of her extensive biography. Connie Stewart will be talking about Braided Capital, public-private partnership for the Behavioral Health Crisis Center. And Connie, as many of you know, is the Executive Director of Initiatives for Cal Poly Humboldt. In her role, she leads efforts on behalf of the university in community, workforce, and economic development, and serves as its government relations lead. She spent 11 years as the executive director at the California Center for Rural Policy, CCRP. She is also the former mayor and former member of the Arcata City Council. Connie, the floor is yours.
Oh, thank you so much. I have prepared a slideshow, but I just wanted to acknowledge that we have a lot of partners here in the room for this project, and so I'm honored to speak on it. And I just would invite all of the partners to feel free to chime in as well. Thank you, especially thanks to Nancy Stark and the team at DHHS who are critical to this work. And let me, with that, share my go to share screen here and show you my PowerPoint. Okay. Alrighty. Can everyone here? Let's do this. And let's go to slideshow. Can everyone see the slideshow now? Great, great. Thank you so much. So this is for those of you who don't live in Humboldt County. This is a picture of Mad River Hospital, which will be the site for our behavioral health crisis triage center. So our origin story is comes really during the COVID crisis, and there were limited options for behavioral health, and most people were going to the emergency room, right? And the emergency room is the absolute worst place for a behavioral health crisis to happen. It's loud. The staff are really trained to deal with, medical crises, and often aren't trained in behavioral health. So people were being strapped to gurneys until they could be assessed as to whether they could get care or not. In some cases, police were bringing patients in, and so they were being detained against their will, and in some cases, they got violent. And so at the beginning, there was a call for people to get together, and the question was, how do we get them out of the emergency room, right? And so the community was having a bunch of meetings about that. And I realized that that's really the wrong framing question. And one of the things I've learned in in my career is when you ask the right question, the community rallies behind, and you funding falls from the sky for projects. I think that's an important lesson for RISE folks to understand. Like, it is important to take time to work with the community to get the right question. And the right framing question was, how do we address family members um, who are having acute crises with dignity? And that's a question they can get everyone in healthcare and everyone in the community leaning in. So the second we asked that question, really, like I said, money started falling from the sky. So we started thinking about, like, what are our intended results? Like, what do we really want to have in the community? And it was really about expanding the continuum of care in behavioral health so that you had the right kind of treatment that you needed at the right time in a timely manner. And when we looked at our community, we have we're blessed with having supervirons in Humboldt County. Um, but we didn't have a lot of continuum of care that we needed, although some of it's being built, and not just by this project, but by a lot of work in the community to make sure. And then, also there were different conditions, right? You can't have adults and youth in the same in the same space. And so really the idea came at, can we get a single space that has multi licenses so that you can you can triage care, you can have a variety of care at the same location. And can that facility then facilitate outpatient care for somebody? So when they come with a crisis, we're able to stabilize them and get them to the right care inside the building, but also interconnect them to care in the community for long-term health opportunities. And we wanted to make sure that the facility was built in a manner in which it um, it was a caring facility where people could feel respected. Where I said faculty, where people working in the facility wanted to come to work, right? A nice place. And so one of the things we did was we had heard about the Be Well project in Orange County, and we traveled down there to see their project. And I think we came back and we learned a lot from that trip about a facility that had multi-care options in one location. And so what we've designed is a 2,100 square foot place that has a sobering center, a crisis stabilization unit for both adults and adults, and also has residential residential care for both mental health and folks with substance use disorder. And so all in one facility. So that is really our vision. Um, so let's see. How do I? Okay, so when we thought about so we've engaged with an architectural firm, and they've used the kind of essence pictures that you would see in a Redwood Rises territory. And the image I'm about to show you will change a little bit, but this is the first and I apologize to all the partners who are seeing this for the first time. We literally just got these. So this is the draft. Don't get too emotionally attached to it, but here, why? Oh, maybe, let me start by also saying, so Mad River Hospital generously provided the space, the location for this. And that was critical because it's already part of a hospital complex. So it was already zoned appropriate. So we didn't have a lot of NIMBY issues or sighting problems. And I think the other thing that's really important, and I can't believe it took me this long to mention, is that we had both governmental folks and private industry and all of the providers in the area trying to work on the solution together. And so really, often you've heard of public-private partnerships. This is a private-public partnership, right? Where Mad River Hospital stepped up, agreed to find a location on their campus. And actually, that location is right next to United Indian Health Services. It's located away from the neighborhood across the street, but it's centrally located in town. And zoning was already provided, so we have a very low hanging fruit for getting permits for this project. So, and because they were private, they're able to move a lot faster than the county. But the county was critical because the grants that we were applying for required matching funds. And so the county was able to provide us with $2.6 million in matching funds, and I'll get more to the money, and be a partner on the project. So that allowed us to go for our first grant funding. It's very interesting. I can't let's see if I'm having problems going to the next slide. So let's see if we can figure this out. Hold on, there it is. Okay, so here is what the facility can. There's only going to be one bay here, and we hope to be able to afford solar panels or get them donated. But here's a first rendition of what the building could potentially look like. And I think it will be an exciting place to work. And let's see, next slide. There we go. So here's a little bit about the braided funding and that we've been able to raise. And honestly, it has taken less than a year to raise more than $20 million. And as I said, it's a public-private partnership. So because the county was able to put up the matching funds and the hospital was able to provide the land, we were able to rapidly apply for a behavioral health continuum infrastructure program grant in round 5. And so we had $14 million pretty quickly. The building is going to cost a lot more than 14 million, and we are still in the process of raising money. But St. Joseph's Hospital was excited about this project, and they put up $2 million for the project because it's going to help the whole community. And then we were able to get a private foundation to put up $2.5 million. That's from out of the area, but who cares a lot about the Redwood Coast and has invested a lot in behavioral health and behavioral health workforce. And then we were also able to ask for an earmark from Senator McGuire. And the county also has some contingency set aside funding. So that gets us to so you can see we're scrapping together funding to make this project possible. We probably still need between $2 and $4 million, but this is a really, really good start on and as you build momentum, you build success. I mean that would also be my take home is oftentimes when and certainly in the case of Redwood Rise, right, there's some money there, but there's not going to be enough money for a lot of the projects we envision needing in our region in order to help economic development. And so it's important to be able to braid funding, leverage funding, and not only that, but that buy-in from a lot of partners creates a sense of community ownership of a project rather than just getting funding from one partner. So in many ways, I'm incredibly grateful for the extra funding. And I don't think I'm sharing anymore, am I? Can you see me or can you see my screen
You're
still?
still sharing, yes.
Oh, great. Okay, I am trying to stop sharing,
Okay, let
but
me see.
I'll figure that out. Okay, here we go. Stop sharing. Normally there's a stop sharing button. So I
Maybe
can
just
see. Oh,
hit the
here it
button
is.
again.
Boom.
There
There
you
we go.
go.
So I do want to invite Nancy. Did I miss anything, Nancy? Or Deanna's here as well. Um, Nancy and Deanna have been a part of the weekly meetings to help design the building, and ultimately the building will be leased back to the county to to find operators for each of the licenses.
Oh, that was one of the questions there. Who will own and operate the center when it opens?
Yes. So once again, this is a great partnership, right? So Mad River will own the building, um, and um, and they will lease it back to the county. And then the county will, I anticipate that the county will go out to bid for providers and provide services there as well.
And I had asked a question, and there just is Cal Poly involved at all, or what's the idea with the Cal Poly on that?
Yeah, why am I giving this presentation, right?
I
Um,
don't know.
Because I am the chief fundraiser and cheerleader for this project, and I have the
Okay.
honor of hosting a group that has been meeting for, I think, 7 years, which of all of the major CEOs in healthcare, and human services in Humboldt and Delaware County. And so in my role, as champion and chief cheerleader for all things healthcare in the region. I've been honored to try to be the head fundraiser for this project. So I guess I should look in the chat and see what other questions
Greg
are.
has one. How is operational funding secured in the long term?
Well, that's a really challenging question to ask right now. Nancy can, I can try, but you
Sure.
can, or do you want to go there? Yeah.
Sure, Greg. So we'll be billing Medi-Cal and private insurance. It's largely federal financial participation from Medicaid. We also have the drug Medi-Cal organized delivery system that'll support a lot of the substance use disorder features of the project. And as Connie said, that's challenging right now given the federal landscape. The only thing I would add is that just kind of tacking on to, reflecting on what Rod and Miranda were talking about is really it's about collaboration in rural, right? In rural, we don't compete, we collaborate. And um, I went through a decade of very tense meetings around behavioral health and having people in the emergency rooms. And really building those relationships, traveling down to Orange County with hospital representation, right? And really building those relationships and having a glass of wine after the day is done, right? It's around building relationships in rural and collaboration, never, collaboration and coordination. So I really heard a lot of what Rod and Miranda were talking about in Connie's presentation as well.
Yeah, I,
Note to self, wine for reservation or
wine
relationships.
always helps with healthcare challenges. The other thing, really honestly, is that there is not a family um, anywhere in this country, I think, that hasn't been touched by behavioral health. And if you can tap into that energy, um, it's powerful. And there is not an industry in our region that doesn't want us to provide better access to all sorts of care. And the return on investment from providing that care will lift all industries in our region. And so that is, I mean, that message is loud and clear every single time we talk to any other industry. When we first started the CEO group, um, actually, it was started with funding that was supposed to be given to the construction industry. And the construction industry said, we don't need this money. Give it to healthcare, because if we don't solve our healthcare problems, we're going to have a hard time in the construction industry. And so that funding led to the creation of the CEO group, and also some some private foundations helped, where Robert Wood Johnson in particular. But it led to the recreation of the BSN program. It led to more. It led to the work Angela's doing, who's on this call, around K-16 healthcare access. All of these programs have been built, um, partially because other industries gave CCRP the funding to say, you've got to start working in healthcare.
Can't have a functional economy without healthy people.
Mhm.
How about as a foundation?
So any other questions that I didn't answer, or should I turn it back over?
Looks like
Oh,
Rod has one for you.
Hi, Connie, thanks for the presentation. We've been working with the hospital in Lake County, Sutter Hospital there, and considering building a crisis unit like this. And one of the challenges I know around behavioral health is just it it takes quite a network. I mean, there's such a expanse of severity of the struggles that people have with behavioral health. So you have a mild to moderate who can, meet with a counselor regularly and maybe go on some meds that can even be prescribed with their primary care provider rather than a psychiatrist. Um, and then you've got, the extreme where, somebody needs actually some inpatient care and might be heavily sedated for a while, or, so it's kind of quite a spectrum. Well, remind me what community you're in, and what other services are around available to help meet that spectrum of need.
well, I'm gonna turn that one over to Nancy, because we in Humboldt we have a whole range of behavioral health options that are coming online or have come online. And so rather than me try to rattle them off, Nancy, why don't you speak to them?
Sure. So we do have a psychiatric health facility, a PUF, in Humboldt County called Sempervirens. I know that Mendocino County, very exciting, is building one right now. Very happy about that. Um, we have inpatient and outpatient mental health and substance use disorder treatment. Mendocino County is also a part of the Drug Medi-Cal organized delivery system. So that's another example of rural partnership where we brought in Partnership Health Plan to really build out that organized drug treatment system, from withdrawal management, outpatient, intensive outpatient, and residential. We have also tapped into the BHCIP or BCHIP funding in Humboldt County to build crisis residential treatment. So we have one for adolescents that is currently being built, as well as one for adults. So we've been tapping into really that one-time funding through the BCHIP grants to build out those facilities. Workforce is always a challenge, but we're working with partners that have traditionally had their home bases further south than us. Some, for example, in Ukiah, Redwood Community Services based in Ukiah, and we've brought them up here. Environmental Alternatives, another example where there's been opportunities for them to expand their services to come into Humboldt County. For the Medi-Cal population, mild to moderate mental health is under Partnership Health Plan. So they've been working with the schools to try to build some of that out. And some of our tribal organizations have also been tapping into the BCHIP funding to build facilities and expand their services. And through CalAIM, the Medicaid waiver that California currently has, there is community supports such as housing resources and enhanced case management. And those benefits recently came online in the last 2 years, and those are growing as well and bringing new providers into our rural counties. Hopefully that's helpful.
Yes, thank
I
you.
was going to say, and now you know why I turned it over to Nancy to answer that question. I think once again, that speaks really to the importance of braiding fund, like braiding things to make it work for your community, and taking that leap of faith, that services are going to be available. We're never going to be able to take our finger off of the go with healthcare. It's always changing, it's always challenging, but I think we're getting a lot more sophisticated about braiding funding.
Excellent. Perfect timing again. This is a very timely group today and well organized. So thank you for that informative presentation. Moving along to our third and final for the day, focused on funding and financing opportunities with the California Healthcare Facilities Financing Authority, CHFFA. We have Brock Lewis, Staff Services Manager, who received an MBA in Finance from CSU Sacramento in 2012 and started working as an analyst at CHFFA in the Bond and Loan Department in 2013. He's been a manager overseeing the bonds and loans programs for the past 6 years. With him is Rana Mayers, Associate Governmental Program Officer, who has been working with CHFFA for almost 3 years and previously worked in mortgage finance for over 30 years. So Brock and Rana will now have the floor.
Thank you for having us. I will work on sharing our presentation here. Is it? No, Raina will start the presentation.
Good afternoon, everyone. Thank you for inviting us to introduce our programs to you. So CHFA is a state agency that's under the State Treasurer's Office. We were established in 1979, and our mission is to help health facilities reduce their costs of capital and meet cost containment objectives, while also promoting important healthcare access and healthcare improvement for Californians. CHFA is a state agency. Oh, sorry. We have a 9-member board, which consists of members from the State Treasurer's Office, the Controller's Office, and the Department of Finance. And we also have 6 members appointed by various state departments and agencies. The board typically meets the last Thursday of each month here in Midtown Sacramento. Some of the programs we offer are bond financing, taxable or tax-exempt commercial paper issuance for access to short-term low-cost bonds, tax-exempt equipment financing, and direct low-interest and low-cost loans under the Healthcare Expansion Loan Program, otherwise known as HELP 2. And this is the program that I want to introduce you to today. So just to give a quick overview, our HELP 2 program was launched in 1995 to efficiently provide eligible nonprofit and public health facilities with low interest rate loans in a timely and cost-effective manner. We have a low $50 application fee and an authority loan fee calculated at 1.25% of the loan amount. And this is due at funding, at closing. Our minimum loan amount is $25,000 and the maximum is $2 million. Loan proceeds can be used to purchase real property for construction, renovation, or remodeling, or to purchase equipment and furnishings. We also offer refinance loans up to $1 million. I know that when I say refinance, most of you thought nobody's refinancing right now, but Chaffa's refinance rates are 4% with a 15-year repayment term to a maximum of $1 million loan amount. Rates for real estate purchases, construction, and renovation loans are 3% with a 20-year repayment term, and rates for equipment purchases are also 3%, but the maximum repayment term is 5 years. The maximum loan to value is 95%. Resolutions are valid for 6 months. This means that the board approval is good for 6 months, and during this time, all of the loan conditions must be met before we can send her funds. Required collateral, we would collateralize the health facility with a lien on title, just like a regular mortgage. Or if you're using funds to purchase equipment, the purchased equipment would be collateralized for the loan. And you may pay off the loan without any prepayment penalties. So here we just have a simple chart that shows our different loan purposes and their corresponding interest rates and terms. So for eligibility, loan applicants must qualify as a healthcare facility under Chaffa's enabling statute and must meet one of the 3 following criteria. Number 1, the most recent audited financial statement must show no more than $40 million in annual gross revenues. Or the health facility is located in a rural medical service study area or is a district hospital. Applicants must also be a California nonprofit 501c3 organization or public health facility. City, county, and district hospitals will also qualify. The facility must also have been in existence for at least 3 years while providing the same types of services. And finally, Chaffa will need to review your most recent 3 years of audited financial statements just to confirm that they demonstrate both financial soundness and the ability to meet loan terms. And Brock Lewis will take it from here.
So on the next slide here, we're trying to get into the life of a Help 2 loan. So we are continually accepting applications. We have board meetings pretty much every month of the year, usually, and it's typically the last Thursday of every year. So we do have a deadline for each board meeting being the 20th of the month prior to the board meeting. So down at the bottom, the 2 months there are just an example. So say if you wanted to apply for a loan for our July board meeting, which would be held on the July 31st, the application would be due on the 20th of June, the month prior to that board meeting. So, and then just kind of the steps for the leading up to the board meeting would be that. So once we receive the application, we have 4 analysts here. So one of them will be assigned to your application, and they prepare a staff report to inform the board members of the financing request. Basically, just like the borrower's information, project description, financial data, and then our staff recommendation. At the meeting, Chaffa presents the financing request to the board, and then we do ask that the borrowers attend the meeting. We actually, since COVID, we do not require borrowers to show up in person. We do hold it through Teams, so you're more than welcome to join in that way, and it makes it a lot more convenient for borrowers trying to come from far distances. And we just ask that you be available for answers or to answer questions and to provide more details on the project itself. And then the board votes on the financing request at that time, and you would know the decision once they do give their vote. And then, as Raina had mentioned earlier, we just would then need to close the loan within the 6 months after that approval. And then for our closing process. So step one is getting through the approval process, and then step two is the closing process. And from there, we create loan documents for the borrower to sign, like a loan agreement, a promissory note, and a gross revenue pledge. We would send those out to the borrower, and we work directly with you guys. You would get those approved by your board, signed and returned, and then we work with with an escrow company to then close the loan, record the lien, and distribute the funds to you so you can complete your project. One few things to kind of point out. Actually, the main thing is if it is a construction project, it does, since it is state funds, it does trigger prevailing wage. And we just like to point that out because sometimes people aren't aware and it can increase the cost a bit for the project. And then for a construction project, also that would be done over multiple disbursements. So the first disbursement is through escrow, and then subsequent disbursements, we work directly with the borrower to get those funds to you. And then here we just have a example of the process. So usually just it begins with it reaching out to us, and we have a conversation about who you are, what you're looking to do, and then we move into the determining eligibility. And then after that, then you can go through and submit an application where we would then, like I mentioned, we'll write the staff report and run the financials, and then move on to the board meeting for approval. And then that's kind of the process for the loan program. Real quickly, just wanted to then jump into the bond financing program. This is actually how CHAFA got its start, was for tax exempt bond financing. So a lot of our statute is based on the bonds. Eligibility that we discussed for Help 2 was then developed for that. So it's still the same facilities would be eligible for both. Bond financing program, though, there is no maximum to the amount that can be borrowed. It's more up to the ability of the borrower to repay the loan or the bonds. Whereas Help 2, we have the maximum loan amount of $2 million. So as I mentioned, this was our main purpose, was for the tax exempt bond financing. We've been around since 1979, and in that time we've issued 632 bonds to 275 health institutions for a total of $50 billion. Bond eligibility, like I said, is very similar to the Help 2 loan. It's still a 501c3 nonprofit, meeting the definition of a health facility under our statute, being in operation for 3 years, providing 3 years of audited financial statements. The different types of bond financing. So we have the new money. So if you're expanding construction, renovation, purchasing new facility, refunding is just similar to a refinance, just terminology for the bond world. We can issue taxable bonds as well. And then there's also the option for direct or private placement of the bonds. And that is where you work with a bank directly for them to buy the bonds, as opposed to going out to the bond market to have the bonds sold. And then sell the same proceeds for financing, very similar as in the Help 2 loan program. The one thing with the bonds that they can be a bit more expensive because there is a lot of legal teams that are involved with this type of financing, and so they can be a bit more expensive. But like I said, that there isn't a limit on the amount that can be borrowed. And then just kind of what sets CHEF apart. So as Raina had mentioned earlier, the state treasurer is the chair of our board, controller, director of finance, also our board members, and then representatives from various other agencies. As I was just mentioning, so the bonds in general can be expensive, but our costs as far as bonds are pretty low. We just have an initial fee at issuance of 0.5% of the bonds issued, and then we have an annual fee of 0.175% of the outstanding amount. And that kind of takes us through the two main financing programs we have, and we'd be happy to take any specific questions anybody may have. And then actually this last slide has some contact information also, if we'll keep that up there if anybody would like to take that down and contact us directly. We're more than happy to discuss.
Asking what the approval rate was.
Approval rate is in from the
Just-
board approving.
Yeah, just like once somebody goes through your process, are most projects approved? Once, if they work with you on the package to get to the board meeting, there's a high probability of approval, I would imagine.
Yes. If you're getting to the board, if you're getting to the board approval stage, we would be giving a positive recommendation and a very high approval rate. Usually, in that initial discussion is where we would kind of talk about, hey, maybe the financials don't look good right now. Let's wait until we get your next financials that are in a better place, and then that gets you in a better position for approval.
Yeah, that's great. And just a note on the bond financing question, I think you mentioned it. There are rates that you pay, but most often in my experience, they're like paid when the bonds are issued. So you get the money and then you pay both your fees here and then your legal fees along the way too, your municipal advisor fees and so on.
Right. And then that can be, a lot of those fees can be captured from the bonds themselves.
Right.
Yep.
So any other questions from the group?
Yeah, you had one of the requirements on the loan was maximum gross revenue of 40 million. Is that, and that's all sources of revenue? You wouldn't exclude any, if we were getting grants or other things that would be counted as our revenue, those would be included in that $40 million limit.
Right. Yeah. Would be all revenue sources included.
Okay. Thanks.
Got to aim for a down year, right?
Yeah.
And I assume that maybe not assume, but I think that many people on this are, looks like in rural areas. So if the project is located in a rural setting, then that gross maximum 40 million doesn't apply.
Okay.
And it could be above that.
Yeah. Okay.
There you go. See, key point of clarification. Yes, mostly rural here.
Yeah. And that's was one of the main aspects of the program, was to get financing out to those rural areas that may not have as much access to other funding sources.
And how about tribes? Does this work for tribes too, or no?
I think so. I can't think off the top of my head if we've had one, but I know that I've seen in our loan agreement, I know there is some language in there about waiving sovereign immunity, which I think applies to the tribes.
Well, there's some question marks there.
Yeah.
Walter?
I'm not aware of any financing going on in California Indian country, but that doesn't mean that it's not occurring. Some of the things that jumped out to me, I'm not sure if tribal facilities are state licensed, and so that might be sort of a stumbling block there. I don't do a lot of work in this area, so I'm not real clear about it. Potentially could be looked at and barriers overcome.
Yeah.
Yeah, and maybe just if there was somebody interested, we could talk with them directly and maybe get a little more idea of their situation, and we can discuss with legal and how that might work.
Yeah, I think it'd be generally interesting to this region because there's quite an abundance of tribes. And I think just having what we find in a lot of these meetings is, the mechanisms that we're talking about for one reason or another are difficult or not workable on tribal lands. And so I think the more we can have, specific answers to that, I think would be useful. So,
Even that for particularly in Hoopa, I don't know that there would be the option to record on the deed of trust, just because of the nature of the land being held in trust by the United States. There's a process. I know there can be like a leasehold mortgage or something like that attached, but I'm not sure if the state is in tune with that process either. So I see some issues here, but I don't know that they're not fixable.
Yeah,
We'll
and
say-
that's a good point too, because I know that we have run into that with district hospitals as well. Like, we're not able to enforce liens on those properties because they're county owned as well.
Interesting. So that's a follow-up. And then Tina's question about, do mobile health vehicles qualify for help to or equipment financing? Because that I think also gets to the rural character, right? If they could be mobile, that sure would help.
Yeah, actually, so that question came up not too long ago, and we were checking in on that. I have to go back and look at what that response was. It was in specific kind of circumstances. I think they were saying it would be fine. I can go back and look at that response and provide that to the group.
Tina's the point of contact. Yeah,
Tina. Okay.
Yeah. For both of these questions, I think would be interesting. If there's anything you could tell us generally about a relationship with tribes, that would be helpful. And then Kelly, we've talked a lot about collaboration. How do we create the environments for successful collaboration? Well, I'm checking my notes.
I saw Kelly's question in there, and I had a couple of thoughts. I thought I would jump in.
Go ahead, please.
Thanks. I think the short answer is be in right relationship, show up in good faith, do the thing, answer the emails, those are like the teeny tiny steps of it. I've reflected a lot on, not just the successful collaboration that we're experiencing through the Incubate initiative. I mentioned something else in the chat around when Nancy was talking about the successes that they're having with some real effective collaboration happening in Humboldt County across their behavioral health system of care. We're also having a similar experience here in Mendocino County after, a good long time of but when we want to move someone from mild to moderate, it's a whole thing, there's a lot of drama around it. And it was very sort of they were really gatekeepy, punitive kind of conversations that were happening for a long time. And that's just not, that's something shifted. And the reflection that I have on this is there's a couple things going on. One of them is that always and forever, necessity is the mother of invention, always and forever. That's just how it's going to be. And we got real collaborative during COVID-19, and I bet y'all did too. And Arch facilitated 2.5 years of weekly, every week, calls between every clinic in the county, public health, the hospitals, everybody, to just come and be and figure out, oh my goodness, what is happening? How are we going to do this? And it was rough. Like, it was hard. And everybody got to like figure out who we were and what we were doing and how we could work together. And I'm really pleased and actually quite proud that our momentum hasn't died off after the peak of the anxiety and the stress and all of the things that we had to, where the rubber was hitting the road. We were able to say, hey, we became really collaborative, good friends in relationship with each other doing this work during that time. And we've kept that going. And it's about making those right relationships so that when necessity, and boy, oh boy, do we got a lot of necessity going on right now, friends. When necessity comes knocking, we're like, we know who our people are, and we know we want to bring more people into this. That would be my reflection on that.
Rod.
Yeah, I think I'd follow those comments up with just a couple of things. I think one is, it starts with ourselves. We have to kind of break down those barriers in ourselves and say, why are we not being more transparent with our data and what's going on in our organization? Who cares if they know how many visits we had? I mean, at some point you can find that out. It might be a couple of years old, but all of this information becomes public at some point. And so there's a lot of secrecy, or we think we're hanging on to trade secrets when it's really pretty accessible general data that's not something that's really unique to our business. So I think that's changing our own mindsets. And I think Miranda alluded to it, being willing to reach out, get out of our offices, make some phone calls, set up a coffee meet, and just start with some casual conversations and relationship building, and and being willing to share your data and talk through the solutions. And sometimes it starts with a small group, 2 or 3 people, and then it can start growing from there. So those are my thoughts on how to start with the collaboration.
A fitting conclusion to a well-organized and implemented session today. Thank you all very much for making the time, for Tina and Taffy for organizing the sessions and setting a high bar for the other sector table leaders to come. We have our next one will be on the arts, culture, and tourism sector. I'm not seeing our man here today, but we will send him a nudge, and please do come back and join us in 2 weeks. We'll send out information. This will be posted on the website that we shared earlier. Calder, that's it. Calder. We're watching you, Calder. Yeah, thank you all for the time and have a great evening.